Hi, I'm Dr. Janet Pope at Room Now, and I have two of my favorite people I'm going to interview today. So I have Dr. Tom Appleton, whom I work with. He's an OA leader in the field doing basic sciences. He gets it clinically as well. He's an MD, PhD. And I have with me the newly minted professor, Peter Nash. He's from Griffith, as well as many other universities around the coast, including Brisbane area. So, and as you all know, Peter Nash has been very busy on seronegative and some seropositive things at this meeting, as well as dabbling in many other things. So I thought, if I may, Tom, if you can give me what you think are the highlights for OA, then we'll cross over to PsA and then we'll have some more dialogue. So Tom.
Thanks very much, Janet. It's a pleasure to be here. Thanks for inviting me. I think actually it was a great year for osteoarthritis. And actually, year over year, I get more and more excited about all the things that are in the works. It seemed like for a while there was quite a dry period, but there's been a lot. So probably the biggest thing is the updates on the tanezumab story. So anti-NGF therapy for osteoarthritis. And important to point out, this isn't a D-mode per se, but it's aimed at improving symptomatic outcomes, and looks like quite a positive story. I think overall, the tanezumab story is essentially two stories in one. The first is on benefit. Tom Schnitzer reported in pooled phase 3 analyses that at week 16, there were more patients who hit clinically meaningful endpoints in terms of WOMAC score, not just at all, but at 30% improvement, 50%, 70% cutoffs compared to placebo. So good early responses across the board. There was another abstract presented by Tahina Nioji, subcutaneous tanezumab, 2.5 or 5 milligrams. For those who had a good early response, we're actually able to sustain that out to 56 weeks of follow-up. So good long-term profile as well. On the other hand, the other part of the story, or the flip side of the coin, if you will, is really the safety one. And people have been following this story very closely. John Carino reported on abstract 1482, the integrated safety analysis. And so there's this new composite joint safety outcome for joint safety events. And that's comprised of rapidly progressive OA of two types. The first type is the most common by far, RPOA2, osteonecrosis, spontaneous insufficiency fracture as well. So there were events in all groups, and they happened more in the tanezumab groups, and certainly a dose response effect. So there certainly is something to follow here. It'll be interesting to see how the FDA handles this. It's already before the FDA. I think in the future, it'd be nice to see comparison against joint injections, so corticosteroid injections. This was another theme that came through loud and clear this year, is potential concern about corticosteroid injections and what that means for safety. I think it's way too early to know for sure. We need well-controlled studies to look at that. And so probably more to come there. But overall, two stories, benefit and safety, it works, but potential downsides as well. So we'll have to see where this goes.
So I have two follow-up questions for this. So I saw the one set of data, over 3,000, I think 3,100 patients or something. But at the end, and it wasn't all that long a study, there was only over 1,000 that they were analyzing. Is this what happens in long-term OA trials, or what's with that?
You mean just in terms of the total number of patients?
Yes, yeah, there was a huge dropout on one of the abstracts, and I didn't clearly understand why.
Yeah, I actually tried to read into that as well. I couldn't get all the details. It wasn't all in the abstract, but I certainly see there's quite a few people who did not meet the primary endpoint at 16 weeks, and so they were excluded from a number of these analyses. So I think it's important to point out that in the long-term studies, you're really looking at the people who did well. So you're more likely to do well in the long run if you already met the early endpoint. But those are the data.
Great.
And I had trouble with this tanezumab stuff because the higher dose seemed the most effective. The 2.5 wasn't anywhere near as good as the 5, but the 5 had all this avascular necrosis. And I love the way they rename things. Rapidly progressive OA, as if it's a normal, natural thing. It's really AVN and insufficiency fractures. So, the most effective dose had the most adverse events. So I'm just a bit skeptical about tanezumab.
So I guess too, I mean, this has been a long time. We've been waiting for a D-mode. I guess if we're going to consider this maybe an analgesic, an enhancement to standard of care for those who fail standard of care, do you think there's going to be really a market at the type of cost of drug development for something like that? For sure there's unmet need, but do you just think that something can be costed in an area that will help our patients?
Well, I think we always have to keep in mind just how large the osteoarthritis market is. So there'll be some economies of scale that way, and probably the closest correlate would probably be the osteoporosis market as well. You know, things are able to be marketed at a lower cost just because the market is so large. So that's a consideration. I think, you know, it's also important to point out that not every patient is going to be a candidate for this, and I think you're alluding to that. You know, I think the thinking is right now that if people have really failed a lot of conventional therapies for quite a while, and this is, you know, something that they're looking at, there will be a risk benefit kind of discussion that has to happen. Another group that comes to mind, though, is people who may be eligible for joint replacement, but for multiple good medical reasons are not good candidates for that. And so, you know, you're sort of asking yourself, well, what other options might there be? And your threshold for risk might be a bit higher there. So those are some of the clinical discussions I think that would end up happening. But again, we can't get ahead of ourselves. This is not approved. It's still being reviewed.
Great. Peter, can you tell me what you think are some of the highlights looking in the PsA area and either our evolution of thinking or in trials as well?
Well, the big things in the PsA field are trying to establish which PSO patients go on to get PsA. And Jose Scher and Joseph Marola have been doing a lot of work looking at risk factors, which patient will go on and which patient won't. And there's some nice abstracts looking at PSO patients treated with aggressive biologic therapy for their skin. Does it prevent them developing PsA subsequently? And from my reading, I reckon it's about halves the risk of going on to get PsA. It doesn't get rid of it, but it does reduce it. And I think those long-term studies will be very interesting. We now have a plethora of treatment choices. A couple of extra IL-17 inhibitors, one from China, one from Russia. So we'll have at least 5 to play with. And brodalumab didn't make it, so that would have been the 6th. The JAKs are now in the PsA space, and the upadacitinib data is very impressive because it covers all the domains and it has excellent skin response, which the Filgo and Tofa don't have quite as good skin response as the UPA does. No new safety signals in the PsA world from JAKs. Here in the skin cancer capital of the world, we're very cognizant of whether you're going to add non-melanoma skin cancer issues to all the biologics, including the JAKs, and there doesn't seem to be any issue or signal there. So all the domains, including skin, are covered, and the risk doesn't seem to be any different to what we're used to in RA. There's an interesting SECU paper where there's differences between the genders in baseline disease activity and how they respond to therapy. So there's talk of stratifying people going into PsA studies based on their gender now. The thing that they didn't look at, which I've been interested in, do genders have different adverse effect profiles as well? Are there different issues we should be looking at? For example, the JAKs, are we going to see HPV as an issue in our younger women that needs to be looked at, given that there's a zoster signal across the class? So there's lots of interesting treatment choices now. The P19-23 inhibitors looking very impressive. First study ever maximized, which looked at PsA axial disease. So there's a lot happening.
Great. Can I ask you though, on the gender, was it that women just start worse, so they end worse, so they have more pain and suffering, and therefore the delta is kind of the same and they end worse? Or does it really look like a different kind of response?
No, I think we just don't know. I think you're probably right with what you're saying, but no one's looked at it before. So And we've got so much clinical trial database to look at. Maybe we should look at it in other therapies as well.
Yes, makes a lot of sense. And please, because we have the placebo arms as well. So in RA in general, women start with higher pain, sometimes in the RCTs, higher burden of disease, and the delta seems to be the same. So if you start a bit worse, you end a bit worse on average. But
Sure.
it is tough to know if it's just the dynamics of where you start or if there's a difference. So what about the TIC2? So is TIC2, with the phase 2 trial was presented, I think it was a late breaking poster by Phil Meese. Do you have any opinion on that, Peter?
Well, it looks nice. It works very well in PSO. And this is the first study to look at PsA. And I think it'll find a place as well. It's interesting that it's a different mechanism. It's not that reversible JAK inhibition that we used to. It's a covalently bound, permanently bound. And so that's when we have to make sure that there's no downside from a side effect point of view. I mean, the VTE thing is one of those things that we still haven't settled with the JAKs. Is it a class effect or is it a JAK2 inhibition effect? I'm not sure it's adequately worked out yet.
Right. So lots will come. And I think stratifying how we're going to treat PsA is probably going to change dramatically over the next 3 or 4 years because we just have such a plethora. I know there was a talk about dactylitis being higher risk for erosions. And maybe I would have guessed that polyarthritis was as well in PsA, but I might not have fully guessed that. So I think we're going to learn more. So can I open this up to both of you? There were several articles at this meeting on the value of intraarticular corticosteroids, that in one, it was superior to hyaluronic acid. Well, that's not quite true. In one, it was equal on 2 large cohorts of over 700 patients, equal joint space narrowing or need to go on to knee replacement and primary knee osteoarthritis for those who got 1 or more IA methyl prednisolone injections versus hyaluronic. So it didn't seem to accelerate cartilage loss. There is another one, a nice RCT looking at intraarticular steroids plus lidocaine versus lidocaine alone, showing KOOS, KOOS, some outcome measurement was better. And they're going to do some interesting sub-analyses and strongly positive with a small n. And I know, Tom, some of your data that the gait improved post primary knee OA intraarticular steroid injection and maybe helped the quads as well. So with those things in mind, you know, I think that there's been a lot of backlash in the media that intraarticular steroids accelerate cartilage loss or not so good. And they're also, there's a meta-analysis as well, I guess, that analgesics such as lidocaine can also accelerate cartilage loss. So can I have both your takes on what do you tell patients? Do you think we need more data, or do you think we have enough data to keep doing what we're doing and feel comfortable with it?
Well, I'm happy to chime in on that. I think there's certainly a lot to discuss, but I also am I'm optimistic that over time we'll be talking about corticosteroid injections less and less in this area, which will be really nice to be able to do at some point. So yeah, so you're absolutely right. Really mixed effects, and I think that just underscores the pleiotropic effects of corticosteroids. They have atrophying effects on some tissues. They're potently anti-inflammatory. They're also anti-pain for non-inflammation related reasons. And probably have a little, you know, at high doses, it can also have some effects on cell death as well. One of the things that I often think about is, okay, how much and how often and in which patients? So we have to be careful in a lot of the cohort studies that are either uncontrolled or potentially subject to channeling bias, where, you know, these people might have progressed anyway. And unless we have a really good controlled arm, ideally with randomization, we're not really going to be able to answer the question very clearly. And so I always refer back to the study that Tim McAlinden did, and it was published in 2017, so a few years ago now, where they had a randomized trial for 2 years of corticosteroid injection, same dose, compared to saline injections every 3 months for 2 years. And regardless of whether the patients really needed it at that moment or not, they clearly needed it to get into the study, but they didn't necessarily need it every 3 months, but that was the protocol. And yes, they did have a little bit more cartilage thinning, 0.1 millimeters after 2 years of repeated injections, but it wasn't worse than that. And both arms progressed regardless. So I think number one, steroids don't cure OA, and they clearly don't, stop your joint from progressing structurally. They have a short-term transient benefit, and that's clearly reflected in the guidelines. And that's usually what I talk about with patients. And then hopefully we'll have something that'll be better than steroids in the future.
But possibly a little
And
more
for me,
expensive. Yeah, Peter, go for it.
well, for me, steroids just temporary symptomatic relief. And in the new molecules group, we're looking at a couple of very interesting new, there's a modified human angiopoietin-like 3 protein in NeoA, which looks very interesting at preserving cartilage, and one injection is very long lasting. The tanezumab stuff we're looking at again, and another one, if I pronounce it correctly, sprifermin, which led to prevention of loss of cartilage over time. Didn't really do a lot for symptoms, but that if you combine it with a symptom relief, like some NSAIDs or an injection of steroid, and then use the D mode, I think that'll be our approach, because FDA guidance says not only do you have to improve symptoms, you have to do something structurally as well. So I think we'll use a combination on the symptomatic side and on the cartilage preservation side. So it looks exciting in the OA area now.
Excellent. I think my last question, Tom, you had mentioned there's some intra-articular anabolic thing. Can you tell me about that?
Yeah, so just as Peter was just referring to, so sprifermin, which is a recombinant human FGF18, not only slowed the progression, but actually caused cartilage thickening. So this is really a game changer. This is the first time that we have seen an increase in cartilage thickness as a result of a treatment for osteoarthritis. And what they showed was that not only was that thickness dose responsive, so the higher dose, more frequent, was able to thicken even more compared to placebo, but over a 5-year follow-up, that the difference between the treatment group that was most effective and the placebo maintained that same distance. So the cartilage thickness was sustained. So really a true anabolic in that sense. And I think it's very exciting to see where this will go. Probably phase 3 coming very soon. But Peter's absolutely right. Combination therapy is the rule. And that, if you think about it, that's the rule in most of our diseases. So why would it be any different here?
So
just being an old Grinch, the sprifermin was, the increase over 5 years was 0.05 millimeters. So it's like a paper thickness over time, but at least stopped loss.
No, you're absolutely right. Although if you look at 0.1 millimeters as essentially a change in grade of Kellgren-Lawrence grade, so that's actually potentially meaningful. But even more important for me, that group thickness went up while the placebo group went down. So it sort of stopped progression over that period of time. But to your point, Peter, I'm also skeptical, because after the 2 years, it started decreasing in thickness again. It's just that you kind of separated the two groups and they stayed separated. So we haven't yet figured out how to turn off osteoarthritis.
Induction, maybe maintenance, something else. So I did say final question, but there is a burning question and it comes up at every other ACR. So from India, again, a methotrexate study, primary knee OA, but they had to have a knee effusion. They got methotrexate versus I think it was glucosamine, and they did the stats pre-post instead of between groups differences, but a sizable enough N and very, very strong statistics. So should I be dishing out some methotrexate? Maybe it'll prevent psoriasis, which will prevent psoriatic arthritis, but should I be doing that in a swollen knee osteoarthritis, not clinically CPPD, not probably hydroxyapatite, not uric acid, where they're failing a lot of stuff and maybe too young to move on to a replacement?
Yeah, so I think people have been using methotrexate off-label for this purpose for quite some time. The story continues to evolve. I'm not sure this is a slam dunk just yet. You're right, it was compared to glucosamine, and as a 3-month response. So there was a statistically significant response within group in terms of the WOMAC pain. but we didn't actually see the stats compared to the glucosamine group. So I'd like to see that fully reported out. I'll also just mention that Phil Conahan's group has been working on the PROMOTE trial, which was a reasonably sized RCT of methotrexate that did show a clinically meaningful improvement, small to moderate, but still clinically meaningful improvement in the methotrexate group. And we're waiting to see that ultimately published as well. So I think there's more to the methotrexate story, probably more evidence that we need to generate. There was also a hand osteoarthritis trial that showed slower progression in terms of bony damage as well, reported at last year's ACR. So I think it's been more successful in these studies than hydroxychloroquine for sure. And maybe some cautious optimism there.
Great.
I think
Peter,
OA.
yeah.
So OA is not one disease.
Right.
And that erosive OA in the hand, which is so symptomatic, will be very different to, Heberdens and Bouchards that we see commonly.
Later on.
Because, and then even in the knee, one group of OA patients will have a high white count, not so high, but clear evidence of inflammation. The next one won't. So I just, I think that if you're going to have efficacy of things like methotrexate, we really need apples compared to apples. And if you just take a big group and lump them all together, I don't think we're going to have much success.
Great. Excellent. So thank you both for joining us. Please follow @RoomNow. And I'm Janet Pope. My Twitter handle is Janet Burdope. Enjoy ACR 2020. Thank you.